Welcome, everyone. My name is Morgan Harrington, and I am the National Coordinator of Programs here at the American Liver Foundation. I'd like to be the first to thank you today for joining us for Life with Pediatric Liver Disease, The Road Ahead, Embracing Post-Transplant Life for Children. ALF's mission is to promote education, advocacy, support services, and the research for the prevention, treatment, and cure of liver disease. As part of our commitment to the liver community, ALF offers a range of educational programs and resources for both patients and providers. You can find more information at liverfoundation.org. Our new resource is the American Liver Foundation Patient Registry, the first ever patient registry for all types of liver disease. Our goal is to help researchers better understand liver diseases and learn how these diseases and current treatment options impact patient lives. The registry is open to individuals 18 and older in the United States with any type of liver disease at any stage, including transplant recipients. Participation is easy and includes a user-friendly online survey, which will only take about 15 to 20 minutes of your time. Please use the QR code or link to learn more about participation in the registry. Don't wait, share your experience to help change the future of liver disease. We are excited to be joined by our wonderful speakers today. Dr. Jamie Chu is a pediatric hepatologist and professor of pediatrics and medical director of pediatric liver transplantation at Mount Sinai Children's Hospital. A Harvard and NYU graduate, she completed her residency and fellowship at Lurie Children's in Chicago. Since joining Mount Sinai in 2009, she has led an NIH-funded research program focused on sugar metabolism and liver fibrosis. Her clinical research interests include genetic cholestasis, MASLD, acute liver failure, and liver transplantation. Dr. Nitika Gupta is a board-certified pediatric gastroenterologist and transplant hepatologist at Emory University, as well as Children's of Atlanta. Trained in India, UK, and the US, she has over 20 years' experience in pediatric liver disease and transplantation. Her work spans clinical research, quality of life, and healthcare transitions, including funding a teen transition program for liver transplant recipients. Dr. Gupta's research on racial disparities in care has led to nationally recognized interventions. She holds leadership roles at Emory with a national medical board and is committed to mentorship and education. Tammy Martin is a physician assistant at the University of Pittsburgh Children's Hospital with over 20 years experience in pediatric abdominal outpatient transplant surgery. After working extensively in patient care, she now primarily focuses on long-term management. A frequent presenter at national and international conferences, she is also the editor of Pediatric Transplant Manual ebook, which is available through the Starzl Network for patients and families. The image here that you see is going to be our roadmap for today. We will leave this up as we go throughout the discussion, and if you have any questions at all, please do not hesitate to drop them in the question and answer box at the bottom of your screen. We will answer your questions as we are available to. So Tammy, we are going to get started with you because you have the most extensive knowledge within that inpatient care in those first few months. So what do those first few months of pediatric liver transplant typically look like for both patients as well as the family?
So I think that the transplant phase actually starts with your intake into the transplant world for your pre-transplant clinic appointments. And at that time, you're going to meet your transplant surgeons and your transplant hepatologists who are going to introduce what the transplant is going to entail, what your course is going to look like, listing practices as well. And at that time, you'll also meet your pre-transplant coordinator that's going to guide you through that process. Once you're listed on the transplant list, you will spend some period of time on that list, and then you'll receive your liver transplant. Your team kind of changes at that point in time. On your inpatient side, which you'll see the same transplant surgeons that you saw who will care for your child after transplant, and your hepatologist as well. But you'll gain some additional team members. They'll be with you throughout your transplant process. And these include your nurse practitioners or your physician assistants who are your individuals who will guide you through your transplant care while inpatient. They're usually the members of the team who will coordinate care with the transplant surgeons, hepatologists, nurses, and family members, and direct care daily, monitoring your electrolytes, lab values, and medications, and get you prepared for your outpatient phase. Additionally, you'll have a transplant pharmacist who will review your medications daily, review any adverse effects or side effects that can come from these medications, and advise the teams on what medications may be best for your care. They usually also are the individuals who will educate you on your medications as a transition from the inpatient to the outpatient side, so you're aware how to administer the medications, any interactions, and help you to get those medications from your local pharmacy. In addition, there'll be an advanced practice nurse, usually who has a higher degree of a master's degree, who will do the transplant education. So you understand modalities or issues that will happen after transplant and get you prepared and comfortable with post-transplant management and care. Nutrition, one of the biggest things to help you heal, and the best medicine out there is your nutrition. And that will help you to heal your wounds, keep bed sores from occurring, get you stronger, and get you home. So they are a big member of our team who can work on oral nutrition, tube feeds if you need them, sometimes TPN management through your hospital stay as well. Social work is very important. We do stress the families out and the patients out. Just being in the hospital, away from your home, financial issues, insurance issues, and help you get those issues cared for while you're in the hospital stay. Behavioral health team has become very important throughout the years, and we've embraced their usage within our team as a big component. Not only are you as a family member undergoing a lot of stress, if it's an infant, your first child, you have those issues, and then transplant issues on top of it. Or if you have a younger child who has lost control over their body, getting through that phase of transplant, helping them to see some type of control over their care after transplant, the behavioral health team has become invaluable for that resource. And then adolescents who sometimes deal with image issues or dealing with a transplant after transplant and missing out with their friends and those developmentals that happen through time they're missing. So they help to get through that. And then most importantly, your bedside nurse who's there for you 12 hours a day, doing your drains, getting to know you, caring for your child. They become invaluable members of your team.
You mentioned a lot of people that are involved in the care of, the children that are having these transplants. Parents oftentimes, as their kids start coming home, might want to have a night out. So who are the people that they could leave as point of contact if there is something that goes wrong, or maybe a quick refrigerator list just to even have on hand for themselves in terms of easy access, right? If they have their child may be ill, or maybe there's something that's amiss. Who would those contacts be in your mind that you would want to have readily available, and what areas and when would you contact those individuals?
So your main contact after transplant is going to be your post-transplant coordinator. At some centers, it's the same person as your pre-transplant. In some larger centers, they're two separate individuals with different specialties. But that's going to be your go-to person. And then there will be 24-hour availability to them or another member of their team that you'll be able to reach out to for any questions or concerns. Also, most centers, including ours, has a transplant manual for the families that they follow with some guidance, some tips, some common questions, and what to do. So those are the main resources that we utilize.
That makes perfect sense. And that's great to know that there typically can be one point of contact, regardless of the issue, to at least get you navigated to where you need to be. Another thing you mentioned is the transplant pharmacist that can often be on board. What are some of the most commonly prescribed medications after transplant, and how do you explain the importance of these medications to not only the caregivers, but the children if they're old enough to understand?
Right. So there's some certain basic medications that all transplant patients will receive. One of them is an antibiotic called Bactrim, and Bactrim is utilized to protect the lungs from any bacterial infection, from a certain bacterial infection that you see with patients who are on immunosuppressant medications. And so we'll put that patient on that medication. It varies from different centers how it's administered, and actually the length of time also varies between different centers. Some do it for a period of 1 year, some do it for many years, and some do it for lifelong. And so the other medications you'll typically see are nystatin, and nystatin is to prevent a fungal infection, or what we call as thrush, and it's a white plaque in the mouth that can occur when you're on these immunosuppressant medications. We typically tell the patients to swish and swallow so you can coat the esophagus. Younger patients can't do that, so we'll use a swab in the mouth to get as much as we can. That medication will go away as prednisone, which is used as an anti-rejection medicine after transplant, goes away. And prednisone, there's an IV form of it that is usually administered at the time of transplant to help the liver adjust to the patient's body and become accepted. We use high doses at first, and then through time, we will wean that down. If you're on, sometimes you just get a one-time dose at certain centers, and sometimes you wean it down over about 3 months. The high doses can lead to sometimes high blood pressures, high blood sugars. And then if you're on it for a very long period of time at very, very high doses, we worry about the bone strength that can lead to broken bones in the future. So those are reasons why we want to get that medication down. And then the most important medication that we give, that is the anti-rejection medicine, it's called tacrolimus is the generic name. The brand name is Prograf. And then the prototype when it was developed was called FK. So you'll hear those nomenclatures throughout your transplant life if you use them. But that's our mainstay of medication. It is started at the time when you're transplanted a day or two later. And we have certain levels that we would like the patients to be at, depending on where you're at, where your time frame is at a transplant. So if you just came out of transplant for the first 6 months, we want a higher dose level. And as you get further out from transplant with no rejections, we'll lower that level through time. And by lowering that level, the one main side effect of this medication is it can cause some damage to the kidneys. And so if we lower that drug, we can minimize the amount of damage to that kidneys. And our main goal of this medication is to give enough so the body doesn't recognize the organ as being not part of that person, but not cause harm by infections or kidney disease. And so it's a fine balance. And as you get further out from transplant, you can give less and less drug usually.
I really appreciate you explaining so much in depth about what that immediacy afterwards and the drug medications look like. One of the things that can often come up is with children, they can be unpredictable in terms of taking medication. And oftentimes vomiting can be induced by the taste of medication. So I know this could vary from center to center, but thinking about you guys as center specifically, what is the protocol if a child vomits after taking, say, tacrolimus or Prograf? What does that protocol look like so that parents may feel better equipped if they do have children that either spit out the majority of it or they do vomit that up relatively quickly?
So we usually recommend if they've had a throw up within 15 minutes of you giving the medication, we want you to go ahead and re-administer that medication. After that time frame, we say don't worry about it and just move on with your day and go on with the next dose in the evening or the next morning.
That's great to know. Shifting a little bit more forward to kind of those first few days again, right after transplant, but thinking more about the surgery itself, what are complications that parents should be on the lookout for in those first few days?
Right, within the first few days and probably the first year, you can see some complications develop. And this is where I tell parents that after transplant, each patient's going to develop their own story, and no two patients are the same. And it's our job to help you get through that story and get through these complications. Initially, you can have some bleeding when you come out of the operating room, and your child will have some drains that come out, and we can see if they've had some bleeding. Sometimes we can give medicines to make that bleeding stop, but occasionally we have to go back to the operating room and correct those vessels that might be bleeding, fix them so they stop. We can also have what's called a biliary leak, and basically the bile duct of the liver it has a leak in it, and so we'll sometimes through time we'll go ahead and we'll put a drain in and collect that collection, and through time we may have to put another drain in to another part of the liver and help that to heal, and it just takes some time for that to get better. And antibiotics to make sure there's no infections that brew, but it is usually a fixable issue through time. We can also get blockages that develop within the bile ducts, and that usually develops over the first few months. It's not initially. It can develop in the next 3 to 6 months after transplant. And with that, we use our radiology team, interventionalists from radiology who specialize in this, who can help put some tubes up into those bile ducts and basically open up that bile duct to let the bile drain easily. And it's not a surgery, and it is fixed. It just takes some time. And then one of the other two other complications we get are related to the blood vessels and developing blood clots. Initially, when you come out of the operating room within the first few days, we will sometimes see the hepatic artery get a blood clot in it. If it's right after surgery, we'll go back to the operating room, remove that clot and fix that blood vessel. If it happens later on, we'll give some medications to help to fix that through time. And then the portal vein is usually if it's clotted later on in time. And again, we can go back to our specialists in radiology who can go into that blood vessel and work to open that up and stent it open, so that we don't have to worry about that clot anymore.
Before we wrap up your section, I want to ask a question that I think a lot of parents really have top of mind even before their child receives a liver transplant. And that is, how do you identify and manage the signs of rejection? What does that look like, especially with acute rejection early on, or maybe chronic rejection as they progress?
And I think rejection is a scary term to a lot of parents. And we try to say that this may be part of the process of getting a liver transplant. Your highest rates or time frame you're going to see rejection will be in the first few months after transplant, as we're trying to get that liver to become part of your child and be accepted. We'll sometimes see rejection, and usually that can be treated with steroids and increasing the amount of tacrolimus that we are giving, and then we lower that through time. Occasionally, there's an IV medications that are a little bit more potent, if you want to give potency, but it'll degree that'll go more after the T and B cells of your immune system, and that will help. And we'll lower those. That is a one-time dose or a couple of days doses, and then we'll increase the tacrolimus as well. And again, throughout the time frame, we'll lower that tacrolimus. I always tell patients, if you have one rejection, you may never see rejection again. It doesn't mean you will always see rejection. It's just at that point in time. Probably the hardest part of transplant that we tell our families is maybe not at the time of transplant, but when our patients become adolescents. And we worry about them taking their medications every day because they're feeling wonderful and they're going through life, and they'll skip a dose or they'll skip a couple doses, and then it'll cause a rejection to happen at that point in time. So we used to think that the surgery was the hardest part, but we think that later phases, making sure they take their medications may be the hardest part.
Well, that was a perfect transition for us to sort of shift gears over to Dr. Chu to start addressing what do that period of 3 to 5 years post-transplant. And maybe for some of the older children, we are starting to age into that adolescence category. And we're talking about medication monitoring and adherence in patients. So can you tell us a little bit more about what are the ongoing care needs of these children now that we're hitting that 3 to 5 year mark for them?
Yeah, thanks so much, Tammy. That was a really great summary of the immediate post-care. I think the time period between 3 to 5 years ends up being kind of a return to normalcy. So the amount of medications really that most children are on during this period is just one. It's just your tacrolimus or your Prograf. Kids are back in school. They should be in any activities they want to do, sports, dancing, clubs, swimming, contact sports, whatever that really is. There should be really no activity restrictions. In terms of eating at school and at home and outside of the home, all of those things kind of return to what a sibling has in that family that didn't have the liver transplant. So, kids really, we encourage them to kind of just be integrated back into what normal life looks like. And for many of the kids that are transplanted early on, they won't remember even all of that time for the surgery. Um, I think that the labs and the visits are, usually once a year by that time. But to talk about the rejection, even before adolescence, where kids start to get really busy and stressed and not take their medicines on time, in that 3 to 5 year period, also families are getting used to being like, not having to see their liver team every 2 months. And sometimes, even if you have never missed a dose, you can still reject. So at most centers, you will still get labs around average every 2 months, even if everything looks so good, because rejection, you won't have symptoms. You are not going to be able to tell if your child is rejecting. This is why your liver team needs to see those labs. We call them surveillance labs, looking for rejection essentially, and any of those longer term infections like EBV or Epstein-Barr virus, things like that. But really, from every 2 months, what we're looking for is making sure those Prograf levels are in the right range, which is definitely lower than they were, in the short term of following transplant. So it's Prograf levels, which are usually by then you're on a good stable dose. The weight isn't increasing like, from age 10 to 11. But if it is, then we would increase the dose accordingly based on the level, but really looking for rejection. So we right now, as a liver field, do not have good predictors to say whether your child could have one episode of rejection early on and never have one again, or have never had one, and then all of a sudden you're 5 years post-transplant and you have an episode of rejection. This is why that is so important that you continue to get your labs. And I think throughout this time period, also your nurse, your PA, your transplant coordinator still is your person. It's your point of contact. It's that person that has known you since transplant, and obviously your hepatologist and your surgeon also, but that person is the one that you'll have different questions now. And this is the purpose of this, webinar, to say those questions of what happens if my kid throws up within 15 minutes, or, all of these things about that changes in the 3 to 5 year. Could I give my kid sushi? Could I go to camp where there's a lake? Right? Things like that. And for the most part, the answer is as long as things have gone smoothly and now you're on a lower dose of Prograf, that's your only medication. The answer to that is usually universally yes. But I will stop there and,
No, that was wonderful. You answered so many of the questions that I know we oftentimes hear in terms of, what sports are children allowed to go back and play? And I heard you say, you can play contact sports, you can go swimming, you can sort of return to that level of normalcy that siblings are participating in. And we talk about swimming in bodies of water that maybe aren't pools or the shower. And you mentioned that's okay to go swimming in lakes. And again, returning to that same level of normalcy that, a sibling who hasn't had a transplant is experiencing. And I think there's a lot of comfort that can be found in those comments where you're in those early stages that Tammy just discussed, where you feel like there are so many things we're not allowed to do. There are so many rules. And here we are 3 to 5 years out, which doesn't feel like that long in the grand scheme of things, where things are loosening up and we are having that return to normalcy, as you mentioned. One thing I want to really address is over-the-counter medications that can be taken safely. Thinking about supplements specifically, we're talking about vitamin C or elderberry, things that we see oftentimes on social media being promoted, especially during cold and flu season. How do you address that with your patients who do have these immunosuppressed children who are maybe looking for ways to boost their immune system during those rough winter months?
Yeah, that's a great question. I would say the answer is probably the same pre-transplant versus post-transplant, and is actually a general no. So that you'll always have family members that say, "Oh, I heard milk thistle is good for the liver." Listen, your liver post-transplant is presumably at this time working really well. We do not need supplements, and in fact, and Dr. Gupta will talk about this more for the teenagers and when they're involved in weightlifting and things like that. But supplements, as a general rule, are a no. And we have liver pharmacists can look, but we don't know enough about those. Those are not FDA regulated. You can't go to a pharmacist and get every single component of what's in that supplement. And one of the main jobs of the liver is to metabolize whatever we eat, including medications and supplements. And so there are unknown risks of those supplements based on either the supplement, where you're getting them from. It's unregulated. You don't need it. Even for like seasonal allergies, things like that. Your liver team can recommend safe over-the-counter medicines that are okay for your liver transplant. But supplements are a general no. I do see like good questions in the chat too. So please feel free for our audience to just keep putting your questions in, and we can answer them either at the end or during this time. But thank you for those questions, and please feel free to keep putting them in.
Thinking sort of along the lines of supplements, but maybe parents want to try to boost the immune system through food naturally. Are there any foods that should be avoided during this post-transplant period, or things that might have drug interactions that would occur with the foods?
Okay, good question. So foods really are grapefruit juice and pomegranates, right? Grapefruits and pomegranates are the ones that really inhibit or stop the how our body metabolizes your pro-graft. And so that can lead to really high levels. So we say no grapefruit, no pomegranate. But the word of like the thoughts of feeling immunocompromised and like, do I need something to boost the immune system? I want to just kind of say that at those levels at 3 to 5 years, the levels of pro-graft are actually not high enough. You're not on the prednisone anymore. You're not on CellCept, things like that. It's, you go from 3 immune suppressants to just 1 at a lower level. You're not actually immunocompromised in the fact that we feel nervous that you can't go to school, be around flu season, things like that. Now, vaccination obviously is routine vaccination, like the flu shot, things like that are always recommended. But really, I don't want the thought to be like, I always need to boost my immune system. In fact, that pro-graft keeps your immune system in check. It actually keeps it at a great level. So we don't want to perturb that. And leave that to your liver team to kind of help manage those levels of immunosuppression, but it is very low.
So thinking along those same lines, talking about the concern again of if we don't take care of ourselves, or maybe children are stopping their medications unknowingly or missing a dose here or there, as they are starting to age out of care for the adult, maybe caretaker who is helping these children with their day-to-day regimens, how do you help with the anxiety that kind of comes along with loosening the reins on children, as well as maybe the children are starting to have the acknowledgement of what rejection could bring for them? How do you help support parents and the patients with those fears and concerns as they're starting to age up and becoming more aware of those moments?
Yeah, this is a great transition question to Dr. Gupta too. I will just say in that 3 to 5 year, it's joint meetings, like joint visits, it's education between family members and the child in there, right? Which is presumably school age now. So I'll transition to Dr. Gupta to kind of answer that as what happens in the teenage years.
Well, thank you, Jamie. That was great. And thank you, Tammy. Like Tammy said correctly, I think the hardest thing is really teenage years and transitioning them. I mean, surgery is very hard, I know, and but this also is another very hard period. So I'll talk a little bit about how we do it. And I do want to apologize. I may have to take a little cough break. We've had a virus circulating in our family, so 4 out of 5 are down with coughing. So my apologies for that. So we started our transition program at Children's Healthcare of Atlanta in 2011. So it's been several years, and I've been working with teenagers. We started at 14 But the main reason for starting a transition program, and now a lot of centers have that, was because we realized that this was a high-risk period. So, to Morgan's questions, how do you deal with anxieties? How do you deal with, middle school, high school kids now saying, hey, wait a minute, I don't remember this transplant. I see the scar, and you're making me take this medicine every morning and evening. I'm out on a date or I'm out hanging out with my friends. I don't want to take this. So it becomes these are normal things, right? Tendencies of questioning, of just your independence you're gaining. So rebelling or wanting to fit in and be normal, and whatever we may explain, you may explain to the kids, hey, you are normal, but hey, I'm taking this medicine, this is not normal. So it is a very difficult time period even without a transplant. So as caregivers and as parents, what we really have to do is partner and into supporting our a child who's now a preteen, a teenager, and then a young adult. And by partnering, I mean, when we started this clinic, the whole focus was on, oh, we have to make them independent. And I completely still agree. We do have to make them independent. We started visits where we had parents step out, and we tried to encourage visits by themselves. But then over the years, as we gained experience, we realized even as adults, we like to have support, right? When we go to the doctors, we want to have support. So what I've seen is the kids who do the best are where the parents and the providers, we are like guardrails. We are like around them. We let them grow. We empower them. We do not enable them. We do not give the medicine in their hand, but we do check. So we don't give up. We don't back off. We don't say, hey, you are 18 now, it's all you. No, it doesn't happen. Life, we all need support. So we've kind of evolved into that model, where when we start this clinic at 14, I wish I could start it earlier, but it's just the bandwidth. But I'm really talking to the patient, and I'm really trying to make the patient answer the questions. And that is where, Morgan, where anxieties come up, they can be addressed. It's so clear. The first couple of visits in a team clinic, the patient is not talking. He's like, almost he or she is like, wait a minute, you're talking to me? Because we all along, we are so used to talking to the parents. And by this time, we've actually become friends with the parents, right? So even for me, and I've been doing this for many years, start with the patient. Hey, how are you? And then before I know it, I'm like, so, I'm talking to the family. So we really try to direct all conversations with the patient. And then I absolutely include the family and say, so first your questions. If you don't have any questions, maybe next time, ask me 2 questions, and then I'll say, Mom, do you have any questions? So we try to empower. Our motto has been empowerment of our teenagers. And we've done many different initiatives in our clinics, educating them. I'll show them the labs. I'll show them, I'll talk about their original disease, and we'll go through that. So again, I feel the more they know, the more ownership they take, and the better the outcome. So we try to really do a shared decision making. So we start at 14. We have parents there in the beginning. Then actually organically, sometimes parents are not there after 18. We encourage driving. We talk about insurance. We talk about adherence. We talk about schools. We have a really high focus on getting our children to graduate from high school, because we actually published a paper where we showed that loss to follow-up rates and adverse outcomes after they transfer to the adult healthcare, they are worse if the child or the young adult hasn't graduated from high school. So, we really try to focus on things which we can change. So substance abuse, we talk about that. We talk about tattoos and piercings. We talk about all normal life things. And then at our center, and every center is different, but at our center, 21 is the age when we have to transfer. So again, just for our families to know, we use these words, and some people use them interchangeably, but they are different words. Transition really is a process, and it has to be started early. Okay. Transfer is actually where it's the final move. Okay, today's your last pediatric visit. Your next visit will be with the adult guys, blah, blah, blah. So that's transfer, but you really should be transitioning to adult healthcare. And so we make the transfer at 21. Some people will ask me, hey, is 21 the right age? Should it be different? What if my patient is not ready? And I kind of base it on like, our kids, when they graduate high school and go to college, not everybody's college ready, but we help them and we provide them resources. So for us, actually having a mandatory age, this was out of my control, hospital systems helped us work towards it. And we've been able to successfully now transition, I want to say almost 120 patients over the last 5 years. And we started a joint clinic with our adult providers to kind of really facilitate that eventual transfer. But transition is a process which really starts early and at 14.
That is great information. You have covered so much with that. And I do have a few questions that I want to break down a little bit just based on things that you had mentioned. And one of those things was sort of the acknowledgement of your relationship with the family and the patient, especially if this is a patient you've known for many years. You've watched them through transplant as they have grown up, and now they are starting to hit those maybe early teen years where they're entering the transition clinic and they start 16, 17, 18. What mental health resources do you all, if any, provide in those transition clinics to maybe help encourage patients if they're having a hard time? Like you mentioned, maybe Dr. Chu mentioned, I see my scar, but I don't remember my transplant. Why am I, adhering to these medications? Or they are concerned about rejection, all of the things that the teenage years can kind of bring on. Are there mental health resources that you all provide during those times?
So we do. We are very lucky that we have a dedicated psychologist who's in our clinic. And back up like 5, 10, 15 years, there were really not that many mental health resources available in the community. But now there are. So even at our setup, we have more outpatient facilities, which we didn't have. So yes, we have a psychologist in the clinic, but it's really a matter of long-term follow-ups. So we actually, in our transition clinic, we do not see any patient any less frequently than every 6 months, because we feel it's important to stay in touch and not let a year go by before we kind of, uncover a problem. So we will refer them to community health services. So, therapy, our psychologist here diagnoses and then helps place the patients. We always try to find resources closer to home. And believe it or not, social workers are amazing at this, at finding resources. And some of the families are too. Google and online is your best friend in this, because there really are a lot of actually free resources available as well to transplant patients, but it's really area dependent. So I would highly encourage you, the one, to normalize seeking therapy and help. And we really do that. If you have questions about scars, if you have questions about, we talk about this freely and openly in our clinics. And again, building that rapport and the trust where the patient is able to, because sometimes, the parents have been surprised. Oh, I didn't know this patient was thinking about that. Or somebody's asked me, I shouldn't be asking this, and please, I don't mean anything by this, but what about pregnancy? And no, and I'm not planning. And, so I'm like, it's okay to ask that, it really is okay. I've had patients parents ask me that for a younger child as well. I think it's a very legitimate question. So we really encourage that and refer them to local resources. But we are lucky as we have a social worker and a psychologist in our clinic. But we also prepare the patients, because once they transfer to adult healthcare, these resources are not as readily available. But again, what I tell them is they are, but you just have to ask for them. So we also teach our patients to ask for resources. Do you need to see anybody today? Our first visit is with all these providers, but not every visit, because otherwise the visit will be 2-3 hours long, and the teen will not want to come back to the clinic for a 2-3 hour long visit. So we after some time we'll say, hey, do you need to see anybody? Yeah, I was having questions about, my diet, or I'm trying to lose weight, or I'm trying to gain muscle, coming back to supplement questions, which Dr. Chu mentioned. So we have a nutritionist, we'll ask for a nutritionist to see, and if they can, they'll call them back. So again, I think the main message to the families out there are, there really are a lot of resources in the community. ALF has resources, right? There really are resources. You just have to reach out to places. You have to find them and find the best fits, actually.
You brought up a good point asking about pregnancy. And I feel like we've talked about a lot of really hard topics so far. And I want to address some things that may be more fun for parents who do have these aging up individuals or children. What about families? What does that look like for transplant recipients? Are they able to have families, male or female?
So yeah, so if you look at some old data, it said that liver transplant patients cannot get pregnant, and that's really old data. So I don't know why. Maybe our patients followed those and didn't use protection, and then we showed new data that actually their fertility rate is even higher than the general population. So I don't think it's really higher, but I think it may have been that myth which was circulating earlier that liver transplant patients could not get pregnant or have bear children for men, but that's not true. So we've had patients in our program, 18 and over, and unfortunately some younger as well, but they've become pregnant and have had healthy pregnancies and healthy deliveries. The only word of caution here would be is the unplanned ones which don't go well. So really, and I say this again to my 18 and overs, a pregnancy is always better if it's planned, especially things like CellCept. So any patient who's still on CellCept, like Dr. Chu said, most patients are on monotherapy by now, but there are some who've had repeated rejections, might be on dual medications, might be on CellCept. So CellCept, people will say you cannot get pregnant on CellCept. But I rephrase it. You actually can get physically pregnant on CellCept, but you should not get pregnant on CellCept because it harms the fetus. So you don't want to get pregnant while you're taking CellCept. So CellCept has to be stopped before conception. So all our, 18 and over females, we proactively, I make an effort to see, can I stop CellCept? Can I switch it? How long has it been since the third, fourth episode of rejection? Have they been on CellCept without any rejection 4 or 5 years? Let me lower the dose. Let me see if I can stop it before I transfer them over. But if we cannot, we still distill this. Every time you do not want to get pregnant on CellCept. But if you have a pregnancy, you can continue Prograf, you can continue prednisone. We even had a patient whose liver numbers went up, and I was talking this with the adult folks. We wanted to do a liver biopsy or not. We went back and forth. We actually avoided a liver biopsy, increased the steroids, got the numbers under control, went on to have a healthy delivery and healthy pregnancy, a healthy baby, and the numbers normalized after. So it just has to be managed with a high-risk OB, an adult hepatologist, and has to be planned. And then you can have successful outcomes. It's really nice to see those photos of the children we transplanted. Hey, Jamie and Tammy, that ages us, doesn't it? That's the only thing which ages me. I feel, okay, this was the baby who was transplanted when I started here, and now I'm seeing photos of their babies, So it's also very rewarding and gratifying.
That is such a heartwarming way to sort of wrap up where we are at. I did see that there were some questions in our question box, and it does look like Dr. Chu did answer one, but I do want to address this because I feel like there can be sort of a multifaceted side to this. And I want to loop back to Tammy a little bit as well, because she also touched a little bit about controlling numbers to avoid kidney damage. So the question was, is kidney damage inevitable? And Dr. Chu, if you don't mind, I'm going to quickly summarize sort of what you wrote, but it is not inevitable after liver transplant, but it is important to manage Prograf levels to avoid rejection, but also to avoid kidney damage so that you're not looking at a double transplant. However, I want to loop back a little bit to talking about electrolyte balance and what the potassium can look like. Can you, Tammy, if you don't mind, or Dr. Chu, either or both would be great, just talk a little bit about concerns that could be related to the magnesium and potassium levels in children and how we're managing those kidney function numbers, including electrolyte imbalances.
Yeah, one of the main electrolytes we see, like you had mentioned, is potassium, and it's more high potassium levels that we see in these patients post-transplant, and it is related to the tacrolimus. And as you get further out from transplant, you get less and less tacrolimus, which helps that. But we can also look at your diet, and a lot of kids eat a high potassium diet. It's the potatoes, strawberries, apple juice. So you try to minimize, give as less if you can, or water down the apple juice, but no, and keep monitoring that. And then the second electrolyte we worry about it mainly is magnesium. And magnesium can get lost in any stools. If they're having diarrhea, magnesium will be lost there. If they have drains in after transplant, low magnesium. But when that magnesium's low and we're giving a lot of tacrolimus, the concern is they could get a seizure. So we like to give supplements for magnesium and keep them on the higher end to prevent that from happening. But those are two electrolytes that we manage the most. We'll do monitoring of labs in the hospital. You pretty much get them daily. As you get further out from transplant, you'll get them twice a week, once a week, eventually monthly, to every 2 or 3 months thereafter.
Yeah, I also kind of at a bigger level, I would say that those electrolyte issues are primarily when you're still trying to find those higher levels shortly after transplant. The question of whether it's inevitable, how long is that, how many kids go on to get jobs and are, things. Actually, I want to bring it back to the first slide that you showed about registries. So, we represent 3 different centers here. And what's amazing about pediatric liver is the community is very close and tightly knit. So in talking about empowering families and patients, these registries and the studies are so important to kind of say not only single center studies, but across our country, what do those outcomes look like, right? So now I have a baby that was transplanted at 1 and now they are reaching 30s, right? Or 40s. How long do those liver grafts last? How long, what does that look like for the kidney health? Things like that. These are best answered by collective studies like the American Liver Foundation Patient Registry. We have studies in pediatric liver transplantation called SPLIT. And also the Starzl network is an amazing network that is a learning network, learning from patients, having lots of patient input, but also how can we as centers be better, right? Make those outcomes better. So we are working hard to kind of get more data to give families to say this is what that looks like in long term. And so I would encourage all the families and people listening and people watching to really empower yourselves and be part of these registries, because it's not, and studies even, right? Like we want to learn about how can we recognize rejection sooner. What are those biomarkers, but also like what does life look like? And though that is answered best by multi-center studies.
I really appreciate your expansion on what those registries and studies really do offer. It is not just an internal information piece, right? It is something that eventually the goal is to help patients across the board and be able to improve outcomes and be able to improve medications. One of the last questions that we have, Dr. Gupta, will be designed for you. I want to end on a high note. I want to end with something to look forward to and something that I think we all also do realistically need to address. And one thing that you had originally brought up was alcohol. You brought up alcohol. You mentioned piercings. I am so curious, what are those restrictions like as children are exploring more in terms of, are they able to get piercings? Do they drink? They've had a liver transplant. We know sort of the blanket standard is no, but thinking realistically, what does that look like for you guys?
Oh boy, Morgan. As soon as I said it, I was hoping nobody would ask me on that, because this is one of the most dreaded questions, because the answer is it's difficult. Okay, so 10 years ago, our transition program, our whole thing was absolutely no to piercings and absolutely no to tattoos. Absolutely no. It was just easy. We all had the same thing. We knew Hep B, Hep C were bad. There was no treatment for anything and blah, blah, blah. But, over the last 10 years, our society has changed. We have changed as people. And our acceptance of, body art has changed, I have to be honest. And we learn from our teenagers. We learn from our Gen Zs. And what we've come to realize is that it is a form of self-expression. And the worst thing we could do would be to say no and not give them any guidance. So we are actually now, we've changed our stance on tattoos and piercings. And when I'm asked, I always say, okay, but, and the but is that you have to get it from a certified place, a clean place. Please do not do it in your dorm. Please do not do it in your basement. I just talk these things loud because I have teenagers. Well, they are now young adults. They are 20 now. But they'll throw things at me. I'm going to do this piercing, and I'm like, what? So and even my patients. So we'll say, please, just be safe, do it. And I have a patient who wants to be a tattoo artist, and so we talk about it. I'm like, where do you get your needles from, and how do you do it? So we really talk about the safety aspect of it, and not so much the tattoo and the piercing itself. So which are now becoming much more acceptable, and it's fine. The problem happens when we and the parents disagree, and then I kind of leave it that, okay, this is a medical opinion, but the parents and the young adult or the teenager, that's their mutual decision. Now, alcohol is a harder one. And gosh, I would not want to go on record to say that anything else other than an absolute no. When I'm asked this question, I just go through the process. I ask the kids or the young adults, how is alcohol metabolized? What have you heard about alcohol? And I tell you, 100% of them know that alcohol kind of goes through the liver, that it damages the liver. It's alcoholic liver disease is known, at least the ones who've asked me. So I'm like, the way I look at it is, you have a liver, you are trying to protect it from your body's immune system, like we were talking about earlier. You're taking immunosuppressive medicines. You're trying to keep this liver safe. You want to have this liver last you a lifetime. So do you want to add any insult to it? Okay. So the insults could be two. One could also be fatty liver. You do not want to gain too much weight so that you develop fatty liver, because fat is an insult to your liver, right? It's another concern. So you don't want to do that. And it's the same with alcohol. Do you want to add it to your liver? Okay. Most kind of understand this and say no. But then it also comes to like, okay, if I was to take one drink on my 21st birthday, or one drink on a social event, will it kind of just damage my liver? And I was like, no, the one drink won't. But if you just want it one day and you decide, okay, the one day is like a binge drinking, well, that will certainly cause you a problem. So I say absolutely no to binge drinking, absolutely no to regular alcohol, but occasionally, on occasion, one drink responsibly, sensibly, maybe, but while understanding the risks you're taking. Yes, I'd hate to go on record saying anything else other than no alcohol, but that's the reality.
No, and I appreciate that. And we do have one last question that has popped in briefly, and we have just a minute left to answer it. And I will open this up to whomever feels comfortable answering it. The question was, have you seen patients having increased allergy issues after transplant, especially when they are indoors during the winter months?
I think this is a really interesting question. And, we have seen increased allergies. I don't know if you mean like seasonal allergies, but things like, different immune reactions to foods, something called eosinophilic esophagitis can be possible, different allergies for sure. And it's the idea that we are changing the immune system a bit, but we don't exactly know why. And it's certainly not universal. So it's not that every child or that has a liver transplant will develop new allergies, new intolerance of foods, things like that. But it is certainly possible. It's hard to know whether that's actually related to the liver transplant, or then adults develop different allergies based on, stage of life, things like that. But it's a great question. It's a great question to talk to your liver team about, and let them know if your general pediatrician has diagnosed that. If it's seasonal allergies, like you said, when you're indoors, certainly there are antihistamines that are safe for the liver. But so it's an evolving question. I think it's a great question. And more to come.
I appreciate that answer. I think that we have addressed some really great points today. We've addressed some really interesting questions and unique situations that arise really only in this post-transplant space. I cannot thank the three of you enough for being here with us today. And we are just so grateful for your expertise and the time that you've taken to hopefully answer some questions where this will help sort of keep these questions moving and these conversations flowing as they go into their own appointments. I do just want to give a quick thank you again for all of our participants for being here today. And if you're looking for any more information after our webinar, we encourage you all to join us at liverfoundation.org. You can also find more information about our virtual as well as our online support groups there, and also opportunities to become involved as an advocate. We have more additional resources that we'll be linking in our YouTube later on when this is posted. We will link to the Starzl Network as well as the Transition Clinic. And we invite you to connect with us on our social media platforms. We are on Facebook, Instagram, LinkedIn, X, which is formerly known as Twitter, as well as YouTube. We truly look forward to staying in touch and stay tuned for upcoming webinars. Thank you so much.